Welcome, everyone, and I thank you for being here. I understand that we are currently competing with a sunny afternoon and with a music festival, the Francophonie, that are going on the street not very far from here. So we thank you for being with us. But with the quality of the four panelists that we have, I have no doubt that there's no competition with what's going on outside. So over the next hour, our four panelists are going to provide their own perspective of the state of the union, if we can say, of personalized healthcare in different parts of the world. The session will be divided in two parts. The first part being a presentation from each of our four panelists, and the second part being more discussion with the panel member, where you will be invited to ask your question as well. So without further delay, I will invite our first panelist to come and present his perspective, which is Personalized Medicine, the Changing Landscape of Healthcare. And I will invite Edward Abraham, President of the Personalized Medicine Coalition.
Thank you very much, Michelle, for that introduction. And I want to begin my remarks by thanking the organizers of the conference for putting on a really stellar conference addressing all the issues in personalized medicine. And the way I see this final session today is really a kind of summing up of what we've learned in the past 2 days at this, as I said, excellent conference. So while everything might have been said, everything's not been said by everybody, and I'm going to try to pull out some of the themes that I think we've heard by reviewing some of the issues that personalized medicine faces with a special attention to what's going on in the United States. So it's been mentioned that a year ago, President Obama issued a precision medicine initiative. And I think this was really exciting because he called attention to the field and attention to the promise. He said that in some patients, for example, with cystic fibrosis, this approach, personalized precision medicine, has reversed a disease once thought unstoppable. And he's suggesting that what we've done for cystic fibrosis, we can do for other chronic diseases like diabetes, like cancer. Now, by doing so, he set the bar very, very high. And we can ask, and I will give you my preliminary answer, whether the United States government is doing all it can to advance this paradigm. Well, we can leave that till later. It's been also noted at this conference that physicians, and we're going to be talking about this in the next hour, have said that they've always practiced personalized medicine. And because I'm not a physician, some physicians like to tell me that. They say that every time they see a patient, they personalize treatment. And that's actually true. And goes back to Hippocrates, who noted that it's more important to know what person the disease has than what disease the person has. And Osler, as has also been noted by another speaker, as the founder of modern medicine, has understood and reminded us that people are different. And this is the basis of personalized medicine. And there's no way that we can get around that fundamental understanding. People are different. Now, what is different today is that we have new molecular tools that allow us to target treatments to the right patients at the right time. Personalized Medicine Coalition is an education and advocacy organization that wants to promote personalized medicine. So if you were to ask what bees are buzzing in my bonnet, it is, we're going to see this developed faster than it might otherwise be. We define personalized medicine as an evolving field in which physicians use molecular diagnostic tests to determine which medical treatments will work best for which patients. by combining the data from those tests with an individual's medical history, circumstances, and values. Providers and patients can develop targeted treatment and prevention plans. That's the goal, and I will argue in the next 5 minutes or so that we're well on our way to accomplishing that. Now, it's very important to remember, especially when we hear from skeptics about personalized medicine, what the benefits are. So we can diagnose disease more accurately, select optimal therapies, increase safety, detect the onset of disease at the earliest moments, and obviously, as we learned today, in cancer, that means the difference between life and death. We can shift the emphasis in medicine from reaction to prevention if we know who's likely to get particular diseases. And most importantly, especially if we want to advance personalized medicine, we can also increase the efficiency of the health system by improving quality, accessibility, and also overall affordability. Do we have enough evidence to show that we can reduce systemic costs? No, but that is the promise by introducing efficiencies. It's very expensive to practice medicine that doesn't work. It's not always remembered when we discuss the price of drugs. So it's also important for us to remember that personalized medicine, unlike 10 years ago, is no longer a pipe dream. It's happening very quickly, and here are some selected labels of drugs that you all recognize, and you can see the speed of approval is accelerating with these well-known drugs now on the market, now making a difference for patients. Personalized medicine is also generates some $25 billion in revenues, according to LEK, which developed this slide for us. Now, most of that is in oncology. Many of the drugs are well known. The poster children for personalized medicine are still Herceptin and Gleevec, but other drugs are coming on the market, which I just showed. And they are adding to an understanding that, especially in cancer, if you want to be successful, the treatments have got to be targeted. There is a new landscape for the pharmaceutical industry, not just in the United States, but globally. And according to a survey that the Personalized Medicine Coalition commissioned from Tufts University, 42% of all drugs in development today are personalized medicine. 73% of oncology drugs in development are personalized. Some companies, that's close to 100%. And 33% of biopharmaceutical firms expect investment in the field to increase by a third in the next 5 years. So, at least for the pharmaceutical industry, there's full commitment to this new paradigm. Now, many obstacles remain. I'm going to skip this slide, but this shows you 20% of FDA's new novel drugs in 2014 were personalized. In last year, they were 28%, and we think that this year will be another banner year. So the landscape is changing. Now, the issues that this conference has addressed and that our panel will focus on are, so what are the barriers to development and adoption? And so I would argue that there are a number, and they're noted on this slide. But the three big ones, and our panel will discuss them, are regulation, especially of diagnostics, reimbursement, including diagnostics, but also what we're willing to pay for targeted therapies. And then maybe most importantly, what is necessary to get physicians and other providers to want a personalized treatment. We even here at a conference ostensibly on personalized medicine, we've heard about resistance among the provider community to incorporating new methods into medicine. And we'll be talking a lot about that. Now, there are some other issues as well, but these are the issues that we think make a difference. I would say that the science alone is not going to change a medical paradigm. How we reimburse, how we regulate, how we educate, all make a phenomenal amount of difference. So in other words, the space between the science and the patient is really important and bears our attention, and it certainly will be the focus of the next 40 minutes or so. Let me conclude by quoting Machiavelli, who was not talking about personalized medicine when he said this, but I think it applies. You can read this yourselves, but essentially what Machiavelli noted is, unless people can see something, they don't believe it. So our goal is to make sure that we promote personalized medicine, that we make it available, and that we get it in the hands of providers so that patients will benefit more rapidly than they would otherwise. So I appreciate your time and attention.
Thank you, Dr. Abraham. As I mentioned, we're going to keep the question period for the end. He said at the beginning that everything in this conference has been said, but everybody has not said about, I've not talked about anything, and that's impressive to be able to doing it in 10 minutes. So thanks a lot. So now I will invite our next speaker that will discuss the current and future key initiative in personalized medicine in Europe, Dr. Angela Brand from the Maastricht University.
Many thanks for the very kind invitation, and you will see that already there's a lot going on between Canada and Europe in this field. I'm talking on behalf of the International Consortium Personalised Medicine, and there is a specific challenge group on integrating big data and ICT solutions. So the personalized medicine landscape in Europe is highly committed to personalized medicine. And the way Europe is seeing personalized medicine is an essential part of public health and the health systems. So we always had the level of intervention on the population level, on subpopulation, and on the individual level. So personalized medicine or personal health and care is an essential part and had been always of public health as well and health systems. Then we see it as a very holistic approach to personal health and care in the way that it's not only the omics, for example, it's much more, it's all the health determinants, environmental factors which play a role, lifestyle, even, for example, 3D printing of a wheelchair or of an individual pill drug in the future would be part of it. Also, it covers the whole pipeline of care, so prevention, health promotion, therapy, rehabilitation, etc. Then, what had been streamlined initiatives or concerted actions in Europe? Is there an action plan in Europe? We have been often asked. What about the budget? And first of all, we did a tender, or we are still working on a tender from DG Research. What had been the impact of the projects in the 7th framework of the Commission of Horizon 2020 projects, and what has been the budget? And surprisingly, 10 times more than the US had been already spent in Europe on that topic, and it doesn't include the Innovative Medicine Initiative, which is also a huge initiative under Horizon 2020. Then what we did, we analyzed over 20 European policy reports on personalized medicine since 2006. The first started with a European Health Forum Gastein, which is our highest policy level in Europe, where the policymakers of the Commission, of Member States, of regions come. Then of the Commission itself, mainly DG Research, then the European Science Foundation, the European Alliance Personalized Medicine, which is like the same like the PMC in Europe, and you have already good connections. Then the Public Health Genomics Guidelines, then from Roche, there had been very early a very good report on personalized medicine, Hope from the policy report from the hospitals and from Eurobioforum. Then also in 2012, the president himself of Estonia was behind the e-health report, redesigning health in Europe for 2020. And a lot of personalized medicine key points had been already covered there. Then DG Connect, which is ICT, DG and communication, ICT, developed a strategic research and innovation agenda on the European big data value in partnership in 2014, and at the same time the DG Santé of the Commission, the use of big data in public health policy and research. And then I mentioned already IMI, the biggest public-private partnership in medicine worldwide, which has a huge impact on personalized medicine in Europe, paving the way. And then we had, under the Luxembourg presidency last year, we have all have 6 months, we have a change in the presidency between the member states, so it was Luxembourg. And Luxembourg came out with council conclusions on personalized medicine. The really milestones have been since 2013, and that was a FP7 project, a coordination support action permit running for 2 years, where ministries of research and health and funding bodies had been partners, and Canada, CIHR, was partner there with Etienne Richer, and shaping Europeans' vision for personalized medicine. We developed 35 recommendations and clustered them into 5 challenges. And then following up that, the Commission, together with a member state, launched the IC International Consortium Permit, developing a roadmap of action points, action items in research based on these 5 permit challenges. And it's, for the first time, a really joint effort of 4 different DGs within the Commission: Research, Santé, Connect and Grow, together with already over 26 European member states and regions and Canada. And I heard just now from Etienne that there are 2 letters of intent from Canada, from CIHR. It's one of them. And then supported also by external experts. The lead of 5 challenges is by the different member states. One is by Hungary, the second by Germany, then third one Austria and France together, then was Denmark and Italy. And the first draft was discussed at the beginning of June in this year in Brussels, so just 2 weeks ago. Oops, sorry. These are the 5 challenges, just to give you an impression. The first one, the huge challenge about the citizens and patients, empowerment and awareness of citizens. The second one, integration of big data and ICT solutions. The third one, translational research from basic research to clinical research and beyond. The fourth one, access to market. And the last one, the sustainable health systems. And this was a very systematic, long process with interviews, with analyzing the policy reports, discussing it with high-level policymakers, feeding it back, adapting it, etc. So you sent us 3 questions. What had been the lessons learned from this process? It needs a strong political commitment. So having the member states and Commission and funding bodies behind it was a huge step. Then also streamlining this process systematically, step by step, since 2006, and I followed this process and advice in this process almost since that time. Then, like I mentioned, the systematic involvement of high-level policymakers from all these levels and Canada since 2013. And then that the first step had been the recommendations for research, the 5 challenges, and now the roadmap of concrete research actions will be developed, and what can be done on international level, what on European, what on national, regional level. Then it has a clear vision statement, research as a driver of personalized medicine, and one is establishing Europe as a global leader in personalized medicine research, and also paves the way for the personal medicine approaches for the citizens. And my also personal lesson learned is we need innovation diplomacy, innovation diplomacy, innovation diplomacy. It's more than science diplomacy. What are priorities, main actions, for example, for implementation? I just would like to pick two under the big data and isolation challenges, because we see it as the backbone of personalized medicine research and implementation strategies. One is developing analytical tools, like the virtual patient for clinicians, for example, as a tool. And the second one, feasibility studies on so-called health data cooperatives, comparing different EU health systems. And the idea behind this, at the World Economic Forum in 2012, big data or data had been at the new economic asset besides money, gold, etc. And why should we give Google and others, Facebook, our data and they become billionaires? Why not the citizens themselves? And so, and also the citizen, the person, is the only supercomputer in a way as a holistic data integrator, because all the data, economic, environment, pollution, biological, come together in the person and can be measured. So the person itself is a supercomputer, the human being. Then the system of, the trust system of cooperatives are not new. We know it from agriculture centuries ago. We know it from the banking system. So it's a trust system where the citizen belong to cooperate to a trust system. They create, own, share, control their own data. Then these data can be used by a lot of users, stakeholders from industry, from governments, for registry planning, for surveillance issues, planning hospitals, but also outside the field of health. So it can be data as such, not only health data. And with the owning of money, each citizen has a vote on incentives. For example, what could be done with the money for the community, but people will not get directly money in their hands. And in that way, all people are equally rich because we all share a lot of data. So it's a truly democratic approach for Europe and beyond, about the citoyen, the proactive citizen. And this is highly supported by the Commission itself. Now the last question, what are key pillars that are necessary for successful implementation, or what could be done? I think this international consortium permit really is a very flexible and nice framework between member organizations as an international consortium model, and we have examples already, and it's seen in the same way like the International Rare Disease Research Consortium, IRDIC, or also the International Human Epigenome Consortium. And member organizations use own fundings and rules and policy processes, contributing to an overall aim and the objectives. We have a momentum, I think, and the time is to work together now. Thanks a lot. Merci, dear audience, the organizations, and merci specifically, dear Etienne, for really, you have been really the driver from Canada behind this international consortium, Personalised Medicine. Merci.
Thank you, Dr. Brand. You said the time to work together is now, and I believe that the conference that we have right now is a perfect setup to have that collaboration that you talked to us about, but collaboration to be enhanced. So we'll go to our third speaker, who will talk to us about predictive, preventive, and personalized medicine as national and international healthcare services of the newest generation. So it's Dr. Sergey Suchkov from the Siganov First Moscow State Medical University.
Good evening, dear colleagues. Thanks the organizers for the invitation, and I would just be very happy to share with you some issues of possible mutual interest, unveiling the problem and the model of preventive and personalized healthcare services. On behalf of European Association of Predictive, Preventive and Personalized Medicine in Brussels and International Society for Personalized Medicine in Tokyo, Japan, would give me a genuine pleasure to cordially welcome you to a meeting illustrating the international platforms in integrating efforts for personalized medicine coming from different parts of the world across the globe. To achieve the practical implementation of PPPM into the daily practice, it's necessary to create a new strategy upon the subclinical recognition of biomarkers of hidden abnormalities long before the illness clinically manifests itself. PPPM as the big change to forecast, to predict, and to prevent is rooted in a big and new science to be rooted from systems biology and fundamental biomedicine. Omics technologies which are being implemented into the daily practice. Meanwhile, a combination, for instance, of genomic and proteomic biomarkers, including metabolomics, are becoming of great significance to predict risks of the chronification and thus of disabling, since chronic diseases are preceded a long subclinical, often symptom-free phase or a period of latency, like, for example, autoimmune disorder. I mean canonical one, cryptic latency. Tissue-derived information we would accumulate might be combined with individual medical records, family history, imaging data, instrumental laboratory tests outcome to develop personalized and preventive protocols. But how is the whole data set provided by omics technologies could be comprehended? It's bioinformatics to suit the requirements by applying mathematical modeling and maintaining unified biobanks and data banks necessary for personal health monitoring and for personalized health management. As a result, the patient becomes a genuine data carrier. By integrating bioinformatics and clinical informatics, including cloud technologies, hospital-based networks, and others, both offers unique infrastructure, tools, techniques, and applications to breach those sub-areas. This facilitates the sharing of data mining and information across diverse disciplines and professional sectors. It's just impacts to be assumed for the practical implementation of predictive biomarkers into PPM. Well, two global key objectives of the model are screening for subclinical imbalances and defects with the pre-selection of suitable targets for the next step of protocol prevention, repair of the imbalances and defects mentioned to restore the function and to thus prevent the clinical illness. PPPM is thus a model of healthcare services being tailored to the individual and dictates a construction of PPPM-based algorithm to diagnose, to predict, and to prevent in time. Implementation of the model would require the adjusted technology armamentarium for proper interpretation of diagnostic predictive data before the current model physician-patient could be gradually, stepwise manner displaced by a medical advisor, healthy persons at risk model. This approach should be based on postulates which will change the incarnate culture and social mentality. This concerns the need for novel training programs, since the society is in a bad need of large-scale dissemination of novel systemic thinking and for sure minding. And upon construction of the new educational platforms in the rational proportions, there would be not a primitive physician created, but a medical artist to be able to enrich throughout medical standards with creative elements to gift for a patient a genuine hope to survive, but in turn for a persons at risk a trust for being no diseased. So the exciting medical education would strongly need to be restructured to involve, along with traditional canonical graduate and postgraduate training, pre-graduate, I mean high school preliminaries, to disclose for school children the mysteries of the evidence-based medicine and the PPPM as the entity. Based on current trends and own experience, we have tried a non-canonical approach towards reshuffling the traditional educational tandem school-university to create a team of talented, gifted, and smart teenagers to be engaged into PPPM-related areas. The team has been given a roof under the aegis of European Association EPMA Brussels and started up to move ahead. It's just those people from NIH, Johns Hopkins, who has just contributed a lot, like provided a kind assistance for me to set up this team. It's the first Congress of EPMA to be held in Bonn, where the young group under the aegis of EPMA has been created. It's the second Congress in Euro Parliament in Brussels, where two schoolboys have presented their speeches. Both schoolboys are absolutely familiar, 14 years old, with NGS and mass spec. This is just the team, international team. And finally, last year, on the invitation of American and Canadian universities, including UCSF, UCSD, Mayo Clinic, Institute of Systems Biology, Montreal, Vancouver, the team of young researchers and clinicians were participating in a series of the workshops and summits organized jointly with young students of the inviting universities, whilst demonstrating their creative potential and activity. It's just the senior young members of the EPMA team from different kinds of the world, from USA, from Italy, from Russia, from Austria, and Virgin. It's school kids from Germany, from Russia, from Australia, and from Slovakia. So, on behalf of EPMA, let me invite our colleagues, our partners from all corners of the globe to form targeted international young research team with the upgraded mentality for moving ahead in the personalized medicine affiliated area and sub-areas as applicable to managing chronic diseases to avoid chronification and thus disabling. So thank you so much for the patience.
Thank you for Dr. Suchkov. You definitively point out one specific challenge that we have in the implementation of personalized medicine, but you made me realize as well that maybe we should have made some room for the young researcher and the young healthcare professionals so that they be part of the discussion. So that's a note to take for the next edition of the Congress. So with this being said, I'm going to invite our four panelists and last panelists to come and talk to us about the implementation of personalized healthcare worldwide. So I will invite Dr. Ansgar Hebborn from Hoffmann-La Roche.
Thanks to the organizers for inviting me to this conference on a very, very interesting topic, but also for giving me this quite bold title, Implementing Personalized Healthcare Worldwide, which is quite a challenge. I should probably qualify my contribution. I'm an economist. I work for Roche on the pharmaceutical side. Roche is a large pharmaceutical, but a very large diagnostic companies at the same time, but I still see the world a little bit more through the pharmaceutical side of things. Angela mentioned that the time is now to collaborate. Yeah, the time is now, but you have to be also in there for the long run. I'm on this topic, or have accompanied this topic for about now 20 years. Initially, we called this integrated healthcare solutions, so it was the integration element. There was the event of Herceptin, a first product that certainly for us in Roche, was truly a personalized medicine, you could say. But then there was a long time, where we couldn't come up with other products. And I think during the last 7-8 years, we really now realize that the investment into this area by many, many different public and private stakeholders is yielding the personalized medicines that we have spoken about and have we envisaged for many years. I'm working in a field, I hope that's the, yes, I'm working in a field that has to do with specific systems that are quite crucial to materialize and realize ultimately the benefit of personalized medicine. And our vision for this field of access and patient access is access for all, innovation for tomorrow. Access for all that could benefit from the therapy, not just those in a few privileged countries like Canada or the United States or certain European countries, but access for many more patients in emerging countries, also in developing markets. At the same time, we have to think and consider refueling our innovation engine and to think about how can our internal processes be sustainable to continue the innovative effort. What do we mean with access? We mean that all relevant factors are in place for a patient to have the opportunity to receive the diagnostics and medicine to achieve optimal outcomes. So it's a relatively broad definition, and certainly it goes beyond just delivering the science. Delivering the science is the basis, that's for sure. And so in Roche, with an early start in this field, when you look into our pipeline, I think this is a snapshot out of 2014, we have more than 250 personalized healthcare collaborations in our own pipeline. So collaborated diagnostic and pharmaceutical efforts on specific projects, not just in oncology, as you can see on the left side, and in very different phases of development. So it's really part of the DNA of this organization to consider and to deeply embed the search for diagnostic specific aspects of these programs. Of course, there's more to consider, and certainly to improve the affordability of what we deliver is a key target of initiatives. Why should healthcare systems invest into a diagnostics infrastructure if treatment options are not available? And to ensure that these treatment options are available really means a considerable effort in various parts of the world. These efforts are tailored and have to be tailored to the specifics of the environments, of the specifics of the healthcare systems, or the specifics of the economic circumstances. What does it mean for the more mature, developed markets? Certainly, when we think about pricing and reimbursement solutions, it's to be smarter in how we build pricing and commercial arrangements. But it also means for us something to think about personalized reimbursement models, more specifically tailored reimbursement models to ultimately realize the benefits of personalized medicines. The situation is different, of course, in emerging markets or in emerging countries where we have substantial challenges in a situation where universal health coverage is built, where maybe some private insurance exists already, or where even most of the investment is carried by patients privately. And there it's about international differential pricing. So how can we differentiate our prices to have them aligned with the affordability of different countries and their economic opportunities and possibilities? It's about patient assistance programs for patients that pay for themselves. And it's about being part of health insurance coverage developments that are created often at the same time. So it's a very specific engagement in this end. But also it's about, and much more about, the healthcare infrastructure and to support efforts to build capabilities and capacity in these countries, which obviously a company cannot do alone, which we have to partner with other companies, but most importantly with governments, patient groups, NGOs, and many other stakeholders in these systems. Just here an example of a case study to provide access, ensure that there's access to Herceptin in China for a growing population. So we created patient access solutions here together with an NGO, but also more and more together with provinces in China that were willing to make Herceptin affordable or create coverage for Herceptin for women when they need it. And we certainly have now a rapidly grown population that has access to Herceptin. Still not our population in this country, but it's a continuous effort and a long-term effort. I mentioned personalized reimbursement models. I think we consider that the drugs that are used in this field of personalized medicine are used in many different indications, in different circumstances and different combinations where their relative value may be different. It's important that in a value-based pricing approach, the price can follow the relative value in these indications. What does it mean concrete? It means that we move away from a simple undifferentiated price per vial of a medicine to a more situational price. For example, when the drug is used in different indications, different combinations, or something that's much more tailored towards the outcomes that are achievable by treating a certain patient. All this is ultimately based on the availability and use of data to better understand how these drugs that many consider expensive, how they are used in the healthcare system. And I think it's still quite sad that we know often nothing how these drugs were used, how successful their use was. There are fundamentally misaligned HTA pricing, reimbursement, and funding pathways in the diagnostics world and on the pharmaceutical side of things. While you have typically a national top-down approach to decide on reimbursement and to take coverage decisions at the pharmaceutical side, you have more or less local providers being left alone with their decisions to fund diagnostic or to fund an appropriate diagnostic infrastructure. You rarely have joint discussions about how to optimally implement not just the drug, but also the corresponding required diagnostic capability and capacity. And I think that's a topic that we've, together with other stakeholders, have made for many, many years. But I think it's important to see progress here, even before we move to a next generation of sequencing and other technologies in the personalized medicine space. A big theme in Europe, very relevant for personalized medicine, are diverging evidence requirements of regulators, regulatory agencies like EMA, and HTA agencies. I think here the most extreme may be the EQUIC. While you have regulators that try to accommodate and to be adaptive in their pathways to accommodate a more complex, different type of technology in reaching the market and reaching the right patients early. It's called adaptive licensing or progressive licensing. In Europe, we call this adaptive pathways. You see typically at the HTA side more rigid criteria that typically these drugs cannot fulfill at a certain point in time when HTA kicks in, at the time of a first launch. What we need is corresponding pathways that are able to be flexible enough to accommodate a continuous, more life cycle approach to the development of evidence. The same is needed for pricing decisions. And of course then there are two other areas which are quite important for a company like Roche, probably also for other companies. It's a more direct engagement in strengthening the infrastructure. This is about training in diagnostics and in other areas, and to increase awareness for people to seek support from and within a healthcare system. I think these are very important areas of collaboration with others, certainly not areas where a company can really operate on its own, but has to be a responsible stakeholder and partner to others. In summary, I think we need to make sure that health technology assessments, or how these things are called today, value frameworks, seems to be the name of the game today, reflect the value that the innovation delivers to patient providers and society in their totality. If this is not the case, this will lead to an underinvestment into these technologies. I think we would expect that healthcare policymakers act accordingly and also invest into education, training, and infrastructure that's needed to realize the benefits of technologies that they are willing to pay for. I think we need to work on the pathways for codependent technology. We need to ensure that prices can vary in line with the value that medicines generate in different utilization contexts, but also in different countries with different economic opportunities to fund treatments. And finally, and I think that's very critical, is that healthcare utilization and outcomes are measured and that their improvement is adequately incentivized. We need to create the learning healthcare systems that we've spoken for so long. We are actively, as a company, engaging with stakeholders in all of these areas and invest significant resources in making progress on these topics. Thank you.
Thank you. And I believe I need to switch to this mic. So thank you very much, Dr. Hebborn. Dr. Abraham mentioned in his speech that the industry was fully engaged into personalized care medicine, and we can see in your talk that that's indeed true. Building on that engagement, and one of the Dr. Brandt, when you discussed the key pillars to be successful in implementing personalized care, one of the first element that you mentioned was political commitment. And from what we understand is that there's a political commitment in Europe. I would like to hear our other panelists on what is your perception of the government commitment in your own part of the world on the implementation and the development of personalized healthcare?
Am I on? Yeah. So I would say that in the United States, the commitment is uneven. There obviously is a very strong commitment to research, despite the fiscal challenges that the United States faces, slight increases in the budget for NIH and $1 billion going into the Precision Medicine Initiative, defining the opportunity for the field. That's excellent. We have problems regarding regulation of diagnostics, which are too complicated to go into right now. And as I say, there is downward pressure on reimbursement for diagnostic products. Even as recently as yesterday, prices were cut for sophisticated diagnostics, or proposed to be cut for sophisticated diagnostics. And without diagnostics, you can't move forward personalized medicine. So I would say, because the government is not fully integrated and supportive of the new paradigm, progress will be slower than it would otherwise be.
Yeah, I do believe that healthcare systems are far too much focused on the inputs, on the things that go into the healthcare systems. When you were attending here this conference, I think you're interested in the outcomes, in the potential to create unique healthcare outcomes. And I think only if we put much more emphasis on measuring outcomes or measuring the performance of the healthcare system or in the healthcare system, we can expect that people more actively search and adopt technology and methods and knowledge to create these outcomes. Without this, the focus is on the inputs, and then it's all about the salaries of physicians or the prices of the drugs. I think in the end, it's about the outcomes. It has to be.
My viewpoint is focused, since the outcome would require a lot of new technologies, basic translational and clinical science of the newest generation. I'm practically certain, even sure, that new standards in the higher medical, biopharma, and public health education would need it crucially and urgently. And as soon as we would do it, maybe within 5 or 2 years, we would just change not only the intelligence level, the educational level, even the mentality to move ahead faster and together.
And I would like to add also what I mentioned. Think about that personalized medicine is not only drugs, is not only, it's much broader. It's a very, very essential part, no doubt. But like I gave the example, when I came in the flight with a flight here to Montreal, there was in the brochure of Air Canada the first printed 3D printed wheelchair for a person. So that is really truly personalized medicine as well, which has nothing to do, we don't need any new regulation on that, so we can already do it now and use it. So I think we have much more to offer already now, and on the other part we have to work, go on.
That's a very interesting example. And I could say that for Canada, we do have government commitment as well, because we have no representative from Canada on the panel beside myself. But I would say to steal some of the word of Dr. Hebborn, I think that there's commitment of government on the principle. What we need to see is more commitment on implementing some real action to make it happen. Two other questions, and then we'll open it to the floor. We've heard several challenges that have been shared with us. One being the adoption of personalized healthcare tool in the clinical setting. There was a survey that was done by the Quebec Personalised Healthcare Network a few, like 2 years ago, and with the physician to question them about personalized healthcare, and the total response rate that they got is 8% in total. 7% of the specialists respond, and 1% of the GP respond to the survey, because it was too early and they see no interest in personalized healthcare. So knowing that the clinician is kind of at the entry, and is the first contact of the patient, I would like to hear you on how can we get the interest or raise the level of interest of the clinician for personalized healthcare.
So it's obvious that adoption is not automatic, that there can and there is often resistance in the physician community. I'd like to hearken back to what Dr. Victor Zhao said, that in his answer to the question of what we could do to get physicians to adopt personalized medicine more quickly than otherwise. So he cited 5 things. First was education. Second was the integration of personalized medicine into clinical pathways, which are harder to ignore. Decision support for overworked doctors. Electronic health records, which are going to be crucial to aggregate data and understand how it works. And then data infrastructure that standardizes the data, makes it transferable, and can be shared. And I think all these things, if they come together, will make the lives of physicians easier, which, as we know, are difficult at the moment, and they can and will resist increased complexity. So the question is, how can you make what is complex simple so that they can be implemented?
Yeah, I have 4 points there short under that. I would, first of all, I think we have or should also convince the clinicians about new tools, the benefit of new tools like the in silico modeling, using tools. The second one, I think that's more a hurdle, what we observed in some member states of Europe. We have for example, in Malta, out-of-pocket payment. The personalized medicine would create more transparency, for example, so that would be a directly economic effect on physicians. We see the same in Germany, the individual services provided sometimes by physicians, so it's a threat for them. Then also clinicians had been trained in EBM, evidence-based medicine, and in clinical guidelines, and this is conflicting now. Although we can use it, best available evidence, so it fits still, but not in the way was in the clinical guidelines. So it needs rethinking to look at the uniqueness you mentioned of the individual, and the last one has to do with that the changing role of physicians of all healthcare professionals, and I'm not sure whether physicians will have the role they have now. So the physicians, I myself, a pediatrician, we would be wise to rethink our roles in the future.
So I don't want to be perceived as the imperialistic economist with all his economic ideas to structure this relationship. And it's a relationship between physicians and patients. I think if patients demand more information and search for more information, I think this in itself may trigger also a search process on the physician side, maybe a bit competitive situation, to be and stay informed about treatment option technology and things that come on. It's a challenging environment. I think incentives matter here as well.
To secure the adoption of basics-based personalized medicine for wide, broad clinical communities and audience, there would be just a trio. First, it's educational reforms for physicians to secure the motivation for penetration of basics into the clinical practice. The second, training for patients, and finally, to motivation for patients and clinicians to love each other and reciprocal respect.
And one final question before we turn it to the audience, and we could say that might be the elephant in the room. We are talking about like how vast can be personalized medicine, and indeed it's not only drug. We have seen all the challenge that we need to address if we want to implement it. So how can we afford it?
Well, one of my great fears and anxieties is that personalized medicine will come to be seen as too expensive medicine, and that there will therefore be a resistance, and we know that that is happening. One of the arguments that the Personalized Medicine Coalition makes to advance personalized medicine is that we argue that systemic costs should decline as the system becomes more efficient. I would also suggest that these new medicines provide greater value not only to the system but to the patient. And by providing greater value, it's likely that they would cost more, but those costs will be recovered by a society that will be healthier, work better, live longer. And that ought to be the aim, and it is the aim of all medicine.
Yeah, first I would say affordability, availability and access, there are three different things. And affordability, we had a presentation at the Brussels meeting from France about cost effectiveness of NGS for cancer patients, and it was clearly cost effective, and it's now decided to have it nationwide implemented in France. However, we heard today from Catherine Payne before from the session about also the limitations about the way it's calculated. But Ansgar mentioned before also the value, the cost benefit. I think this is really much more holistic. You're more in that. So it's not only the costs, it's about the preferences. But what I also would like to say, there are countries which are more pro-innovative in Europe, for example, Spain and France, who invest more. Then the UK is now changing to value-based pricing, for example. But what we also see, two other things, that something like joint procurement, which we know from vaccinations, so that member states together by vaccination. So we see it now with Bulgaria and Romania, which are very poor countries in Europe, or also the Benelux, Belgium, Netherlands, Luxembourg, coming together to buy drugs. And then the last point, the fallen angels. I don't know how far is it to which didn't make it to the market, to bring it to the market again, because I think these could be also more affordable and fitting to a more targeted group.
Affordability is certainly of concern to us. We ultimately rely on the utilization of our products very widely, and not just in the US. So I think we have to find ways to ensure sustainability of the model, the R&D model of our industry, but at the same point in time to think about the sustainability of healthcare systems. The dynamic that we see here in this field, the innovative dynamic or innovation dynamic, is due to the incentives that are set. And I think there is a link between the incentives that are set to create valuable technology and ultimately the dynamic that brings these forward. I think it's important to focus and to stay focused on the value that the technologies bring to healthcare systems and not the cost per se. It's the value. And if the value isn't there, we realize we will be punished. Our drugs and technologies are not adopted to the extent that we have hoped for. So in principle, I would argue the system works. It creates the innovative dynamic, but it also creates a strong healthcare systems and payers that are able to say no in areas where they perceive it's not value for money.
No, thanks. No comments.
Okay, no comments. So now we open it to the audience. Dr.
I will have a comment and question. This noon there were people from the government of Quebec, and it was clearly said that they stimulate this research, and then when it should be implemented, they are reluctant because of the fear of the additional cost. And that's that resistance to additional cost. It's present in many countries because health systems are perceived as hitting the wall of the national budgets. So they basically ask us, show us what we can remove from the system in order to introduce these new technologies. And perhaps, and this is my question, perhaps we should be more proactive in it. This afternoon there was a nice talk about screening. Screening based on the genetic risk. Change the structure of the screening. It's actually more effective in the number of the people in whom you save from the cancer of the breast or prostate, and yet you are screening less subjects. So the increased effectiveness, we have to probably show more proactively how it will change the final budget, at least in the areas and it can work. This is my question to you. What do you think about it?
Who want to tackle that question?
Yeah, I think we need to create, yes, we all are asked, and that's not just the HTA agency in Quebec, but it's all providers and others are somehow called to action to think about how we create headroom for innovation. It can't be just a top-level idea, and I think where this has happened, I think certainly the initial ideas are interesting. I think Choose Wisely is such a, you could say, grassroots initiative, but there are other areas where people take informed decisions about things that may not be needed. Yeah. And I think it's important to not centralize the process, but to keep providers in a decentralized manner active to search for this headroom that may be out there.
Yeah, and there is under also the HTA community more and more room now to say disinvestment. What are areas for disinvestment? And I think that's exactly, and when we think about the adverse drug reactions, for example, also there are possibilities. There's a huge amount of money, and that is why it's in a lot of countries number one now from the priorities also. Antimicrobial resistance and how to tackle these, and this has much to do. But I think also exactly what you said, we cannot add. We do it in no other industry. We do it only in health. We add, and this cannot be.
And the other thing is the power of diagnostics is you learn what not to do. And that eliminates waste from the system.
Yeah. But, you know, politicians are not going to remove anything because they will be not re-elected. So we have to show them what can be removed. I think in part it's our duty to tell the society what should be the economic change benefiting from this venture.
One comment again more. I learned now also from economics, from Merit, where I'm based on Maastricht. They are not in health so far, but they are using evolutionary economics to exactly also study that, how the shift of the markets and sustainability of
the basic idea of evolutionary economics is that this knowledge is decentralized. And I think that the big risk is that we bring it to a very high level at an HTA level where in an undifferentiated manner you just cut out whole intervention. I think we have to be more mindful of the heterogeneous need in the patient population, and it's healthcare providers, it's physicians that have this knowledge. You cannot centralize this in Ottawa or in a national capital.
Thank you very much for the panel.
And I saw the organizer walking around, meaning that we are getting to the end of the panel. But I'm going to allow myself a last question and giving the last word to Dr. Abraham. We have been hearing that personalized healthcare have been like all the different thinking have been going on for over a decade. Would you say that we have passed the tipping point? And if not, what would be that key element that will help us to pass that threshold for accelerating the implementation?
So I thank you for the question. I think we're very far away from a tipping point, and I would like to see actually 3 things happen. One is that physicians would no longer say, let's try this. They would know, because they've done the right diagnostic test. A patient, when prescribed some therapy, would say, is this right for me? And then finally, we would no longer talk about personalized or precision medicine or stratified medicine. It would just be medicine. And when we get to those 3 things, we'll know that we've passed the tipping point.
So I would like to thank our 4 panelists. Thank you very much.